Hey everyone, welcome to the show today. And listen, I am incredibly excited and honored to have the privilege to interview someone who over the past 4 months has become a mentor of mine. He was a mentor, he just didn't know it before that. But over the past 4 months, I've had the honor to go through a fellowship with Dr. Morgentaler, and it's been incredible. And at the halfway through, we had a one-on-one encounter, and he at the end of the 30-minute interview, he said, "Is there anything else I could do for you?" And I said, "Well, actually, would you ever come on my podcast?" And he willingly, said, "Absolutely, I'd love to do it." And so that brings us to today. So, Dr. Morgentaler, welcome to Optimized Health Podcast.
Great to be with you, Josh.
So Dr. Morgentaler is truly a world-renowned urologist, researcher, pioneer in the field of men's health, testosterone therapy. I could give you plenty of accolades. He's a member of Harvard Medical School. He's been a part of either writing articles or being listed on articles of over 200 articles around this topic. And in particular, you're going to hear today a little bit about his background as a urologist around testosterone and prostate cancer, but his information, his understanding of testosterone therapy is quite impressive. So let's get started. One of the things that I think you're probably most well known for is just your understanding or your work done on prostate cancer. And this has been something I would say you've really been a leading voice in challenging the idea that testosterone causes prostate cancer. So can you walk us through how you entered into medicine? You've got your own story there of how this all came about, but how you entered into medicine, what that belief was when you started practicing, and then where are we now as it relates to testosterone and prostate cancer?
Yeah, sure. So, so I trained as I'm a urologist, and I did my residency in the 1980s, 84 to 88. And at that time, nobody was treating men with testosterone except for super rare cases where people had pituitary tumors that were affecting them, or the rare guy who lost both his testicles to cancer, something like that. And the reason nobody was treating was because it was believed by everybody, taught in medical schools and training programs, that testosterone caused prostate cancer. Mm. And it was such a strongly held belief, and it was worse than the association of smoking and lung cancer. Mm. I was taught that if you gave a guy testosterone, even for a short period of time, like a few weeks, they were bound to get prostate cancer, and it would be aggressive prostate cancer. And when I came out of my training in 1988, I started seeing men with sexual problems as a kind of subspecialty of what I did. And the guys were desperate. Hmm. And they said, "Doc, my wife is going to leave me. I don't have sexual interest. I don't have any ability to have sex. You got to have something. You got to help me. You got to do something." And I'd known about testosterone because when I was an undergraduate, I worked in a lab for 3 years with lizards. Hmm. And part of the experiments were to castrate the males, which means removing their testicles so they don't have testosterone. And all their normal sexual behavior that they did when they were in a cage with the female, they would just stop doing it. And you've seen these lizards. They're the ones that are down in Florida and the Carolinas. They're about 4 or 5 inches long. They've got this bright colored flap, orange or red underneath their chin, called a dewlap. And normally when you put a normal male in the cage with a female, the head bobs up and down quickly. The dewlap comes out, and it's like the male is saying, yeah, like I'm into it, right? Yeah. And the female does a little push-up back if her hormones are okay. And they repeat it a few times, and then they mate. If you castrate the male and you put him in the cage with the female doesn't do anything. He has no desire. He has no testosterone. And then my project which took 3 years to complete, but my first paper came out in 1978. That's a long time ago. Was to put little pellets of testosterone in the sexual centers of their brain. Mm. And when I was successful in putting it in the right location, which was challenging, the males who had no detectable testosterone in their bloodstream would see the female, the dewlap would come out, the head would bob up and down, and they did all their sexual behavior and would mate. And it was just amazing. And so what I got out of that was, at least for the lizard, that testosterone was a brain hormone, and that it was necessary and sufficient to regulate the entire range of sexual behavior in the lizard, the male lizard. So when I came out of my training and I was seeing these human males who were having all sorts of sexual problems, we didn't have much to offer. This was 1988. It was 10 years before Viagra would come out. And I thought, I wonder if guys are like lizards. And so I gave a few guys testosterone, and they responded really well. And then we were off to the races, because those men not only improved sexually, but they improved in ways that surprised me, because I didn't know anybody that was giving testosterone. It just wasn't done.
Yeah.
Because there was the fear it was going to cause prostate cancer. And so these guys not only improved, like their sex drive was better, their erections were better, but they said, my wife likes me again. I wake up in the morning and I'm optimistic about my day. I haven't felt that way in 10 years. And it occurred to me that this is something that's really special. Like in medicine, there aren't that many treatments we have that change people so much, right? Like we can reduce pain, we can control blood pressure, maybe we can give medicines that help with urination in my field. We have surgery, of course, that can help with, we can take out cancers and things like that. But the idea that you could give a medicine and that guys would feel, one of the things they would say is, I feel like myself again. I haven't felt that way since forever. That was an astonishing thing to hear from people. And so we had, on the one hand, this fear of prostate cancer that I took very seriously. I had no reason to doubt it at that time. And then the benefits that we were seeing for guys. And so I decided I was going to keep treating men, but I had to tell them about this risk of prostate cancer. And the guys would say, I don't care what the risk is, I'll sign whatever you need to sign. And eventually, before very long, in a year or two, I decided that to protect the patient and to a certain extent protect myself, because my colleagues thought I was doing something really wacky and dangerous, I started doing prostate biopsies in men before I gave them testosterone. In my mind, I needed to exclude the possibility that they had a pre-existing cancer that wasn't detectable by PSA, not detectable by, a normal digital rectal exam.
Yes.
Because the belief was if they had any little cancer in there, it would grow like wildfire with testosterone. And what was funny about that became my first major publication. It was published in 1996. It was the results of prostate biopsies in 77 men with low testosterone, but normal PSA and a normal digital rectal exam. No reason for those guys to normally get a biopsy.
Right.
I was only doing it because they were interested in testosterone therapy, and they agreed to do a biopsy first, which wasn't great fun for them. And the old belief that as I discovered, was started in 1941 with a guy named Huggins who went on to win the Nobel Prize. The belief was that two parts. One, that high testosterone was risky, and raising testosterone was risky because it would make those cancers grow. And the other is that low testosterone was supposed to be protective. Part of the story, the narrative around the prostate cancer story, was that eunuchs never got prostate cancer. A eunuch being somebody who lost his testicles early in life for whatever reason. And I'll tell you something funny about that as we looked into it. So when I was a junior resident, we looked up to our chief residents like they knew everything. They were 2 or 3 years ahead of us. They knew the answers to all the questions, and I asked my chief resident, I said, eunuchs, Like there had been some little talk or conversation with the faculty about eunuchs. I said, I've never met a eunuch. How do they know that eunuchs don't get prostate cancer? And he said, and he knew everything. He was a great guy. And he said, the castrati. And off he went. I said, what are the castrati? He said, look it up. So the castrati were these singing groups, males, that went around Europe, and they were famous. They were like operatic singers. And they would they did procedures so that they'd remove the testicles or did something, crush the testicles, so that their high voice would never deepen. And they went around to all the major cities in Europe, and they were famous. But the weird thing is, okay, so the castrati were eunuchs. The weird thing is, as I looked in more, it was fine during residency. That was the answer. You know, my chief resident gave me the answer. But once I started working with prostate cancer, I looked into it, and the last castrati died in the 1920s. We didn't have any method to look for prostate cancer really until PSA came about in the late 1980s. The eunuch story was BS.
Yeah.
It was just nonsense. And there had also been a paper published in the 1960s where somebody went to China, and there were still some eunuchs surviving from the last Chinese dynasty, the Qing dynasty. And they had, I forget, 18 or 28 guys. They examined them. But they weren't looking for prostate cancer, but they had small prostates, all of them. Well, okay. But, you know, it's 18 or 28 guys out of, I think, 10,000 eunuchs that they'd had when the dynasty was around. All of those guys could have died of prostate cancer. Right? Like it wasn't evidence of anything. So anyway, you know, where are we today? The evidence has now been overwhelming that testosterone does not cause prostate cancer to grow, doesn't cause it in the first place. And we now have large studies, like the biggest is the Traverse study that was published in 2023, the largest randomized controlled trial of testosterone with over 5,000 men who got either placebo or testosterone, median follow-up of 33 months. And the rate of prostate cancer was almost identical in the two groups. 12 men in the testosterone group, 11 men in the placebo group got cancer. It doesn't do it.
Right.
And so over the course of my career, I ended up giving men to riskier and riskier situations with prostate cancer. First to men who looked like they were cured of prostate cancer after surgery, then to men who had low PSAs after radiation for prostate cancer, then to men who were on active surveillance where we're just watching them for lower risk cancers, and eventually published data even on men with metastatic cancer. And in none of those cases did testosterone ever do what I was taught in my residency that it was going to do, which is create new cancers or make existing cancers progress like crazy.
And it's fascinating. How many of your colleagues would you say, when it comes to, you know, the way that you practice medicine, how many who are in the research, who are in the, you know, how many, what would you say, a rough estimate of how many people practice that type of testosterone therapy in their practice?
Right. So I started giving testosterone pretty much as soon as I got out of my training. Yeah. And started seeing these guys. So that's, you know, the late 1980s, 1988, 89. I would say that it was at least another 8 years before anybody was giving testosterone to anybody. Yeah. Now, as I've gone through the lecture circuit, and I've given, you know, lots of big lectures, I've had plenty of people come up to me and say, you know, I'm older than you, and I used to do this too, but I didn't tell anybody. And I'm sure that that's true. Yeah. I'm sure that's true. when they say it to me, it's kind of like, you get the credit, but I was doing it before you. In medicine, in research, you never want to say you're the first to do anything because there's always somebody who probably did it before.
Yeah.
So I won't say that, but I was probably the first to be talking about it. And the guys who did it, and I know because I've been in these situations, where you have some guy that maybe you just feel sorry for them or you feel compassionate for them, and you offer some guy some treatment that you wouldn't offer most other people. Maybe they're at the end of their life or something like that, or they're terminally say, okay, what kind of risk really is there if I give you something now? So I'm sure that that's true. But the only people that were getting testosterone before, like I told you, were those rare cases. And endocrinologists would treat those guys. So in my training, for example, I remember a young guy who was probably about 18 or 19, and we removed his second testicle for cancer. So he's a young guy. He now doesn't have any testicles. And we didn't treat him. We referred him to the endocrine folks. Now, there aren't that many of those guys, right? Right. So they would do that once in a while. In every big major academic center, there was probably a senior endocrinologist who saw, maybe 6 or 10 cases a year. That was it.
Wow.
And what I was doing differed from that dramatically in that I was treating men who had 2 normal testicles, normal as far as you could tell. They didn't have hypothalamic or pituitary problems. And they didn't have genetic issues like Klinefelter's or Kallman syndromes. So I was treating relatively healthy men. Most of them probably had lower testosterone just as a function of aging. And, what's funny about it is, so this guy, Huggins, in 1941, published a paper that was huge. And he came up with the first effective treatment, temporarily effective, for guys with metastatic prostate cancer. And what he figured out is that if he removed the testicles, those cancers would stop causing pain for people. And if you could image them, they would shrink. They didn't have CAT scans back then, but guys got better. Of course, within a couple of years, the cancers almost always came back. But it was the first treatment that did anything. And that became the basis for what we now call androgen deprivation. And that's still the mainstay of treatment for guys with metastatic prostate cancer. And it's now 80 years later. Huggins was awarded the Nobel Prize 25 years later in 1966 in medicine and physiology. And because he really came up with what could be considered the first hormonal treatment for any cancer. Yeah. So that was a big deal. But he made 2 kinds of statements. One of which turned out to be correct, and we still follow it, and the other was incorrect. In addition to showing that castration or treatment with estrogen, which does the same thing, it lowers testosterone, he also claimed that testosterone injections activated prostate cancer. And he based it, and I'll tell you this story. I think it's a good story. It's an amazing thing. So I was now giving testosterone regularly to men, not with prostate cancer, but regularly to men without prostate cancer. And my patients weren't getting cancer. And the paper I mentioned before, where we did the biopsies in guys with normal PSA, they had a high rate of prostate cancer, not a 0% rate of cancer, which is what people should have believed. That was published in JAMA in 1996. So I knew that part of the story was wrong, right? Low testosterone wasn't protective, but I still believed that high testosterone probably was a problem. And I thought the same as everybody else. Otherwise, why would we lower testosterone? Right. When guys have metastatic disease, raising it must be bad. Now I lost my train of thought. Where was I?
Well, you're telling the story as far as whether I think.
Oh, right. Yeah. About how so the Huggins story. So Thanks for the reminder.
Yeah.
I'm getting to an age where I used to be able to go on all these tangents, and now I can't go on tangents anymore. It's like, where did I put my glasses? And they're on top of my head. So I was treating a lot of guys with testosterone, and I was now on the lecture circuit. Urologists were very interested in what I had to say, even though they weren't all necessarily following what I was saying. And basically I was saying is there's something wrong with the story. And one guy said to me, who was a prostate cancer expert, he said to me after our little panel thing, he said, Abe, and he was a senior guy with prostate cancer, smart guy, nice guy, Paul Lang. And he said, Abe, your stuff is very interesting, but maybe metastatic cancer is different. After all, Huggins said so.
Right.
Have you read Huggins? And I said, I haven't. Of course, I know about his work. So this was probably about 2004. And it's hard to imagine today that there was a period of time where it wasn't easy to find articles. Today we have on my phone, we can just go on whatever program you've got, Google Scholar or whatever, and you could write Huggins 1941 and it'll come up in 15 seconds with this paper.
Right.
But we didn't have those search engines then. We didn't have smartphones then. So to find and how people had papers, articles, is that when I was academic, every journal that I subscribed to, at the end of the year or every 2 years or whenever I got around to it, I would send my individual printed journals to a binder, a place where they would bind a whole year's worth of journals into a leather-bound thing, and I proudly put it on my shelves. And so I had literature that went to the beginning of when I came out of my training. For Journal of Urology, the Urology Journal, maybe something I did fertility. I did fertility and sterility is another journal. I did it for a few journals. And if you belong to an academic department, they had it going back probably a decade or two from whenever the chief had started doing it himself. But to find an article from 1941 in the early 2000s, the only place to find that was to go to a medical library. And so after that prostate cancer guy told me about, Huggins said this about metastatic cancer, I had to go to the library. And I descended into the Harvard Medical Library called Cantway. And I pulled out from the dusty archives in the basement, blowing the dust off of these old ancient tomes. And I find this article from 1941, and Charles Huggins, who I knew of, he's like the patron saint of urologists, right? He's the only urologist to ever win a Nobel Prize. And everybody knew his work about androgen deprivation. And I read through his article, and at the very end of his article, he says, every man we treated with testosterone had a rise in the biochemical marker they were using, which was acid phosphatase. And the last sentence of his article says, testosterone injections activate prostate cancer. And I remember that moment like it was yesterday, because my palms were sweaty. My heart was pounding, because by that time I had probably a couple of hundred patients I was treating. Yeah. And here Huggins is saying it activates prostate cancer. And I knew that a lot of the men who were candidates for testosterone, when I biopsied them, 1 out of 7 of these guys had cancer, even though their PSA was normal. And I had visions of the Harvard police marching into the library right there and then, putting me in handcuffs and marching me out, and photographers for the Boston Globe were going to take pictures. And my little kids would see me on the front page of the Boston Globe with a headline that says, Harvard doctor, treats patients, causes cancer in his patients, treats them unethically. Because I didn't know any other docs that were doing it.
Wow.
And with that sick feeling in my stomach, I kind of forced myself to reread the article and ask the basic questions like, how many men did he treat? How many men with testosterone? How long did he treat them for? And that result was amazing. So it turned out they said that they had treated 3 men with testosterone, but they wrote articles differently then. It was almost like little case studies. And they showed results for only 2 men. One of those men had already undergone castration. And today we understand that's a special case.
Yeah.
Because the androgen-deprived man, whether he's got cancer or not, his prostate is so hungry for testosterone and other androgens that any chemical made by the prostate is going to go up. And in the end, the whole general concept taught to medical students, trainees, healthcare providers around the world that testosterone causes prostate cancer or causes it to grow was based on one guy where they measured his blood for only 18 days. Mm-hmm. And the results in that one guy go up and down, totally erratic, which is why we no longer use that marker, acid phosphatase, because it's so erratic. So when PSA became available, we stopped using acid phosphatase almost completely. And that's what it was based on. It was based on indecipherable results from one guy over 18 days.
Wow.
It wasn't true.
Right.
It wasn't true. It wasn't evidence of any kind. Now, what's interesting is that Huggins was the preeminent authority of his day. That's why he won the Nobel Prize. Mm-hmm. And in his Nobel Prize speech, which was published in Science magazine in 1966 or 67, he continues to assert that testosterone therapy, even in hormonally intact guys, in other words, not castrated yet, was dangerous and promoted the growth of prostate cancer. And that set the tone for my teachers when I was in training.
Yeah.
And for everybody's teachers. And, what happened is that once, it's funny, people credit me with starting the entire modern day usage of testosterone, which I didn't do directly, but I think I did it indirectly. Mm-hmm. So in the late 1990s came in the wellness concept. And there were people healthcare providers who would inject themselves. They were male with testosterone. They saw what would happen. If they were female, they went on hormone replacement therapy. But they were all nervous about prostate cancer. And as I published my work on testosterone and prostate cancer and challenged it and showed this wasn't right, and Huggins just based it on one patient, the hurdle for people to do that, the degree of fear that they had came down. And I remember giving, it's got to be more than 20 years ago, my first talk to the anti-aging A4M group, the Anti-Aging Association of America. And it was just one piece of what I was talking about with testosterone. In the middle, I say that, there's no clear evidence that testosterone promotes prostate cancer. And people stood up and gave me a standing ovation in the middle of my talk.
That's great.
In the middle of my talk, because they were hungry for some authority. So I was still young, but, I was Harvard Medical School faculty.
Right.
Here's somebody, who is willing to say this, and it's what they wanted to hear. And testosterone was a key part of that wellness kind of movement that really took off in the 2000s.
Where do you hope to see testosterone as? I mean, you've already kind of described what what we see in the literature and your support of using testosterone irregardless. But your understanding and then the actual practical approach, right? When you actually see this play out, where do you hope we are 5 years from now from a medical standpoint and how we talk about testosterone and prostate cancer to our patients?
So, the strange thing now, I'm working on a paper now to try and put a last nail in the coffin of this story. I don't know how easy it is. The amazing thing is how persistent is, as far as I'm concerned, the data are now overwhelming.
Yeah.
There is not one single compelling piece of evidence that raising testosterone in anyone puts them at increased risk of prostate cancer, or even men with a history of prostate cancer makes them at greater risk for having a recurrence of their cancer, and even in men with metastatic cancer that it's going to make their cancer progress more quickly. There's not a single piece of compelling evidence. There are these random stories that come out, data points that are very indirect and not particularly compelling. But we still have guidelines. Most of the guidelines around the world in every society in endocrinology and urology and anything with hormones and sexual medicine, most of them still say don't give testosterone to men with a history of prostate cancer. The AUA guidelines, American Urological Association guidelines, did a good job. It's 2018. And they basically said, we think it's okay to give testosterone to men who appear cured of their prostate cancer, where it's been surgically removed and seem to be at low risk for recurrence. But that's the only group that they say give their blessing to. And I think they say also that people on active surveillance, those are people identified with cancer, but it's low risk and nobody's operating on them yet, until a follow-up study might show that it's progressed in some way. And they say that, the jury is out on that, and there's some data that it might be okay, but they don't recommend it. But most still recommend against it. And what I'm writing a paper on now is why that myth is so persistent. Right? So if you were to ask a prostate cancer guy, please tell me what the evidence is that it is a problem, they've got nothing to show you.
Right.
Other than the belief, which is repeated often, they say things like testosterone drives prostate cancer. And then you can say, well, why do you believe that? And the arguments are, well, there are an awful lot of enzymes in prostate cancer cells that need androgens, testosterone or its derivative DHT. But that's not really a very convincing argument, because what people fail to understand, there's been this idea ever since Huggins that testosterone is almost like a foreign agent for the prostate, right? Where it's this weird substance that just promotes the acceleration of cancer, and if you deprive it, it decelerates it.
Yeah.
Right? Accelerates or decelerates. And of course, what Huggins didn't know, he was just starting with this thing. He didn't even know, it was before the androgen receptor was even identified when he was working. And we know that androgens work through binding to this chemical within the cells called the androgen receptor. And what he couldn't have conceived of is that when the androgen receptor is fully bound with androgen, you can add in more androgen and it can't bind more copies of the androgen receptor because they're all filled. Whatever copies you have are maximally filled.
Right.
So you can add in more. And so what happens is that if you start at the point 0, where there's 0 testosterone around, and you raise it, there's growth of prostate cancer. But at some point it becomes enough, and then it just plateaus. And so I often give the analogy to a house plant, maybe 3 feet high, and water. The house plant needs water. If you deprive it of water, it'll shrink, shrivel. If it's shriveled and it's still alive and you give it water, it'll grow. But once it has enough water, you could have a garden hose running into it 24 hours a day, and that house plant will never grow to be the size of a sequoia tree. In order to grow that much, something else has to happen to it, right? It needs something else besides the water. And that's true with testosterone and prostate cancer. And the other thing people don't recognize, so there's a finite amount you can have, and that's called saturation.
Right.
And we published on that in 2007 and 2009. A lot of people got that concept. They say, okay, testosterone, the prostate cell needs a certain amount, and after that, we're okay. And I think that explains why you can give testosterone to most men whose naturally occurring testosterone level may be low, but it's still at that saturation point or above it. Right? It's around 250 nanograms per deciliter. Most guys under 350 are starting to get symptomatic. The average guy who we treat with testosterone is somewhere between 250, 275 on average. Occasionally there's somebody who's lower, but even if they're a little bit lower, there's not that much room for androgens to still push anything. But the other argument for the oncology types who say, look at all these enzymes within the prostate cancer cell that need androgens, all this biosynthetic activity, is that the prostate is androgens for the prostate is a normal substance. The prostate only grows in men during puberty when it's exposed to androgens, and it develops as a secondary sex organ.
Right.
And it makes about a third of the fluid that comes out when we ejaculate. The guy with a testosterone of 500 doesn't have better prostate function than the guy at 400, right? It's just making some juice, and it makes as much as it can, and it's complete by the time it's probably at 250.
Yeah.
So what people say, well, look at all these things that testosterone is doing, or androgens, testosterone or DHT, in the prostate cancer cell. And what people don't get is that the prostate is a highly differentiated tissue. Highly differentiated tissues often have special requirements. Neurons, for example, need nerve growth factor to grow. The prostate, because it's a sex organ, needs testosterone, which is what drives puberty and sexual maturation. So the androgens are just normal substances for the prostate. Does the prostate need it, normal prostate? Absolutely. If you deprive a man with normal prostate with testosterone, his prostate shrinks. Just like that plant that's been deprived of water. And the key point is that with many cancers of differentiated tissues, breast, thyroid cancer, others, is that what the cancer does, 98% of the biosynthetic ability of that cell is what that cell was doing before.
Right.
They don't have to recreate everything about how that cell works. So prostate cancer still creates glands, just like normal prostate does. They may be altered in size. They're smaller. They may be more back-to-back, we say, with prostate cancer, like the glands are against each other without as much interstitium. But they're doing most of what the prostate does. But they've gained the function in one way or another of growth not being controlled anymore and the ability to metastasize, and in some cases to invade locally. But of course, the prostate cancer cell what they do is those differentiated cell cancers hijack the normal biosynthetic pathways of its normal native tissue. So it's not a surprise that testosterone is used or DHT is used. That's not an argument that raising testosterone makes it worse.
Right.
But if you say, show me the data that giving testosterone to men with metastatic cancer or on active surveillance or in guys with unknown cancers, but it's there that something worse happens, those data don't exist.
Yeah. What's your, in connection with the saturation model? So you've got a guy with 250 nanograms per deciliter, symptomatic, you choose to treat him, PSA of 0.9. And is there a percentage increase that you prepare the patient for on the PSA? Say, hey, if I put you on this, you may see this bump, but what's a number you don't worry about?
Yeah, it's hard to predict, except you can make a couple of general statements.
Okay.
So one is that we have a couple of studies that show that if the level is above 250 nanograms per deciliter and you get testosterone, on average, PSAs do not rise at all in that group.
Okay.
Now, there's individual variation, right? So some people may go up a little bit, some go down a little bit. But on average, there's no change. If they're below 250, so take a guy whose baseline is 225 or 200, he's likely to see an increase in PSA. And the second general comment is that the lower the baseline testosterone, the more of a jump they can see.
Yep.
And the reason it's hard to put a number on it is because it's it's almost like a grading curve, you know?
Yeah.
So, because for example, you can take guys, let's give it a simple case where they don't have prostate cancer. There's some guys who have PSAs of 10, get evaluated, biopsied, and they don't have cancer. Right? If you take those guys and you give them medication that's like androgen deprivation, their PSA can go down to 0, undetectable.
Right.
If you then bring them back to their normal testosterone, their PSA will go back to 10. At some number at some degree of deprivation, that 10 is going to become a 5. But I don't know what that number is.
Okay.
At 5, it's going to become, you go further low, it could be 2.5.
Yeah.
So, you know, what I tell people is I don't get caught up in what that number is. I tell my patients when they start off at low numbers, I say, I want you to know that your PSA is almost certainly going to go up. And the final number, we don't know what it is. I'm not going to predict it, but we'll know in 3 to 4 months where your new baseline is going to be. And from that point on, if your PSA continues to rise, then we worry about prostate cancer. But otherwise, we're going to leave it alone.
Okay. So that 3 to 4 month window of time to sit and observe and watch is crucial. That's great.
Yeah, we create a new baseline in 3 to 4 months. Yeah.
Let's. I know we don't have a whole lot of time, but I do think this is important because I think there's another area where you've been influential, and just in even the fellowship that I did with you, we talked a lot about reference ranges, right? And and how to how did we get there? And we don't have to spend a ton of time on that, but just what's for a clinician who maybe is just getting started. And, there's, 3 or 4 reputable, guidelines out there, societies. How would you tell them to really navigate those waters around reference ranges, treating men who have low testosterone symptoms, but they're in range? Just expound on that for a little bit, if you don't mind.
Sure. So, most healthcare providers, if you order a series of labs, it's impossible to keep all the reference ranges in your head, what's normal, right? So we look at the lab sheet. It tells us the result, and then it tells us what the normal range is.
Right.
Forgive me. And the problem with testosterone, and those ranges are usually quite useful, right? You can see if a level is high, low, normal, or roughly normal. The problem with testosterone is that for none of the labs is it established on a clinical basis.
Right.
Which means that when it says it's low, that doesn't correspond to when men start to get symptoms. And the reference ranges, you could have 2 labs that have different reference ranges. Their results may be the same, but one will categorize a guy as normal, and the other will categorize him as low.
Yeah.
Forgive me. I had my fellow did a simple but really interesting project years ago where he called up 25 different labs. He asked them what equipment they used, what assays they used for total and free testosterone. Some of these labs used the same equipment, the same assays, the same little kits. And at the end of the day, out of 25 different labs, there were 17 different reference ranges for total testosterone.
Wow. With
a huge variation between them. What does this mean practically? It means that nobody who really feels like they've got expertise in testosterone uses lab reference ranges.
Right.
So most of the guidelines that are put out are unrelated to those reference ranges. So AUA, for example, uses the value of less than 300 for total testosterone. The Europeans use 350. And the Endocrine Society, for some reason, in their most recent one, came out with a very low value of 264. But there's a lot of variation. My own opinion is that free testosterone is much more important than total. They're different, and free testosterone gets complicated too because the reference ranges are off for that, and there are different units that people use for it. So if you get a calculated free testosterone, which is what most of the big labs will do, Quest and LabCorp, Endocrine Society used to say less than 65 picograms per mil is low. I think they made it even a lower number now. AUA doesn't even mention free testosterone, although I think it's the most important. But I would treat men, I think the right number is if it's less than 100 picograms per mil, and the guy's symptomatic, I think that's a good candidate for treatment. And we've shown and published data that show that men who just have a low free testosterone, like I'm mentioning, even with a quote-unquote normal total testosterone, do just as well as men who have classically low total testosterone.
Right. What's your take on calculated versus direct free testosterone assays?
Yeah. So the direct assay, also, which is like a radioimmunoassay, or now they use chemiluminescence, gets really bad press, which is bizarre because it's actually a very good assay, at least the most common one that's out there. It has a different set of reference ranges. It's like on a different scale. It's almost like comparing Fahrenheit and centigrade. So for the one that's out there, we used to use the value of 1.5. If it was less than 1.5 nanograms per deciliter, we thought that we considered that low. It's the equivalent of 100 picograms per mil with the calculator. Yeah, but I think it's a good test. We published data that showed it was completely blinded. We had two labs within Quest do the direct test and calculated, or we calculated it actually, and they came back perfectly corresponding.
Yeah.
But they just have different numbers that are associated with them.
Yeah. So in a clinical standpoint, right, if you have the ability to order the direct free, but in a pinch, even using that calculated level of free testosterone would be more than appropriate as far as helping. Sure. You can't necessarily make the diagnosis, but it is a way clinically to utilize that information.
Yeah. And I would also suggest for people listening in who are somewhat unfamiliar with this, if you start dealing with free testosterone, I would encourage all your listeners to do that. Throw in an SHBG level, sex hormone binding globulin level, because the reason that in the vast majority of cases where total testosterone and free testosterone differ is because the person has a generous or abnormally high SHBG. Right. SHBG is a carrier molecule that binds testosterone, binds it so tightly that it's not biologically available. And the more SHBG you have will tend to make your total testosterone look normal, but your free testosterone will be low because less of it is free. So if you've got a discrepancy between total and free and you say, gee, how do I understand this? And the SHBG is up at the upper end of normal or abnormally high, that's your explanation. The reason they differ is because they've got a generous SHBG level. Right. And then all the pieces fit together.
And again, just out of curiosity, when you see a high SHBG in a male, are you doing anything different? Or are you saying, hey, this is going to take a little bit more of a saturation effect, right? Because you've got higher SHBG. Do you use boron? Do you use long jack or anything of the herbal idea for SHBG?
I don't, and I know there's a lot of efforts to do that, and some of those sort of supplements and herbal stuff may work, but I think that it's completely unnecessary. As long as a person understands that it's free testosterone that gets into the cells.
Yes.
And therefore, free testosterone is the right thing to be looking at. Then SHBG doesn't matter. It's just a distraction. It's a distraction. So, and when you give testosterone, and there's also a mistaken concept that people have. They say, well, if I've got a guy with high SHBG and I give the guy testosterone, most of it's going to be bound up by the SHBG and won't be available. What happens is that if you got the discrepancy and you treat somebody with T, they're both going to go up,
right? Total
and free.
Yeah.
You don't care what the total is. The only thing is, and I do caution people who are doing, if you're treating people based on free, and the total is well within the normal range, like I've treated guys with total testosterone of 500, but their free was low and they were symptomatic. You have to tell them that their testosterone may go above the normal range.
Right.
If you treat them, their total testosterone. And that's important to document too, because we live in a day and age when other people, other docs, are going to see our records.
Yes.
And somebody may see bad stuff happens. We live in a litigious society and things like that. Someone gets a stroke or a heart attack and they say, oh, testosterone did it. This guy was weird. Why was he being treated with T? And they say, look, his total testosterone was normal.
Yeah.
And look, with treatment, it went above normal, above 1,000. Well, you need to give the argument, document why you're treating, and that you recognize total testosterone is going to go high and may exceed the normal range.
Yeah. That's great. Listen, thank you for taking an hour out of your day to educate our listeners and just to give us your expertise. And wow, I mean, just, I so appreciate, really, truly, I think the word that comes to my mind is pioneer. And you say it without even saying it, but when you were indirectly leading the charge in the 80s and 90s, and I think about how we now have the ability to stand on the shoulders of guys like you who fought the good fight and continue to do it. And I just want you to know, thank you for people like myself who get to really, truly stand on your shoulders and continue making a difference in people's lives without having to go through all the extra hard work that you did. So I really appreciate that.
Thank you, Josh. That's very kind of you to say. Let me tell you, there were some hard moments in there. Yeah. And some scary moments. But my touchstone was always to do what was right for the patient. So if I was going to do something that might have felt scary, I would tell the patient, I say, listen, most docs will think this is going to cause you prostate cancer. I don't think so for this reason. But it's certainly possible. I don't have all the answers. And they would have the choice whether they were willing to accept that risk or not. And so I learned from patients who were willing. I always did what I thought was right for the patients. And it was my patients who were often willing to push me. Yeah. Like my first patient that I treated on active surveillance, he pushed me to do it. I'll sign whatever you want. I'm willing to take that risk. First guy with metastatic cancer. What are you waiting for? I'm going to, I've got metastatic cancer. Like, how much worse can it be? I'm going to die of this thing. So I give most of the credit to all of them. Yeah. But I appreciate your kind words. Yeah. Thank you.
Well, absolutely. And we'll be sure to put some links of your podcast and your book. I think it would be excellent for a lot of our listeners to the Testosterone for Life book. It's an easy read. I make all of our clinicians here in my practice read that as a quick, just little brief intro to what we're doing and how to make a difference. And you do a great job of sharing a lot of patient stories in that book. So, Dr. Morgentaler, thank you so much.
It was a pleasure. Good luck to you, Josh, and good luck to optimize you.
All right. Thank you, sir.